Hello, coding students. This is a recorded lecture for Chapter 7, Neoplasms. There are a lot of things going on in this Neoplasms chapter, so buckle in and let's get to it. Okay, so in this chapter, by the end of the chapter, you should be able to identify groups of neoplasms classified in ICD-10-CM, identify a neoplasm as being benign or malignant based on what terms are used, apply the coding guidelines that relate to neoplasms to select or sequence your codes, and then select the code diagnosis from case studies. Okay, so these are 5 definitions that you want to be able to differentiate so that when you are looking in the record, you know how to code your neoplasm. Malignant neoplasms are tumor cells that extend beyond the primary site, attaching themselves to adjacent structures or spreading to distant sites that are characterized by relentless growth and are difficult to cure. The term invasive is often used to describe the extension of tumor cells to other adjacent sites, resulting in spread called metastasis. Benign neoplasms are not invasive, do not spread to either adjacent or distant sites. They may, however, cause local effects such as displacement, pressure on the adjunct structure, impingement on a nerve, or compression of a vessel, and therefore, at that point, those would require surgery. Carcinoma in situ is when tumor cells are undergoing malignant changes, but they're still confined to the point of origin without invasion on the surrounding normal tissue. Neoplasms of uncertain behavior are when the ultimate behavior of certain neoplasms can't be determined at the time they're discovered. So they can't distinguish between if it's benign or malignant. So it's in uncertain behavior. Neoplasms of unspecified behavior, so don't confuse those two. These are when uh, the neoplasms are not otherwise specified. So terms that are used are growth, neoplasm, new growth, tumor, and you're at a point where you haven't done enough testing to know where the neoplasm is. So it's an unspecified behavior. Um, So a code from category D49, which is the unspecified behavior, would not be used for a neoplasm treated in an acute care facility because we would have more definitive information. Always should be available in, in an acute care facility, an inpatient status. Usually this will occur when a patient's transferred to another medical facility or further diagnosis and possible treatment needs to occur and more diagnostic studies. So they're still working up the patient and they need further studies. Um, so that is when you would use this unspecified behavior. All right, so some terminology. Morphology is the form and structure of the neoplastic growth. Metastasize is the spreading of cells. Encapsulated is surrounded by a capsule. Biopsy is a removal of tissue for pathological examination so that they can differentiate between if it's malignant or benign. Okay, so malignant neoplasms, also known as cancerous growths, are very life-threatening. The characteristics include relatively rapid growth, possible metastasis, um, interference with normal cell growth, and cells that are disorderly. And this just kind of shows you the cellular growth patterns, and that one at the bottom on the right, that is cells that uh, are cancerous. You see that they're all different shapes and that they're rapidly growing. Common malignant neoplasms, liposarcoma, osteogenic sarcoma, leukemia, um, carcinoma of the breast, esophageal adenocarcinoma, or adenocarcinoma, sorry, um, fibrosarcoma, adenocarcinoma of the uterus. Benign neoplasms. So benign neoplasms, they're not malignant tumors. They're usually not life-threatening. Their characteristics are relatively slow growth, encapsulation of the cells. Cells appear similar to the tissue's original origin. Cells are not metastasized. All right, and then these are some common benign neoplasms: lymphoma, osteoma, chondroma, fibroma, meningioma, sorry, uh, neuroma, and then fibroid. So if you see these, so in benign neoplasms, you're missing like that carcinoma, right? Or the blastoma or the sarcoma. You're missing that middle part here because these are benign. They're not malignant. So here's your knowledge check. Based on the term listed, state whether the neoplasm is malignant or benign. So at this point in the recording, you can pause right here. You can, go through and, write down your answers, record your answers, and then you can go back and press play and see what the answers are. So at this point, I'm just going to advance our slide for the answers. Neuroblastoma is malignant. Osteoma is benign. Fibroma is benign. Adenocarcinoma is malignant. And chondrosarcoma is also malignant. Okay, so behavioral groupings found in the neoplasm table. So when you go to the neoplasm table in your index, you are going to find malignant neoplasm, benign neoplasm, neoplasms of uncertain behavior, and neoplasms of unspecified behavior. They are going to be located within the table along the top in columns. So on the left side is where you will find your site of your neoplasm, and then you're going to have to pick from one of the columns. Is it a malignant primary, malignant secondary, malignant carcinoma in situ, or is it benign, uncertain, or unspecified? So in locating your neoplasm code, your first step is going to be to go to the alphabetical index under the name of your neoplasm. Then you're going to follow any cross-reference notes that are present there, and then it will reference you to the neoplasm table by site. Then, as instructed by cross-reference notes, and then your step 4 is to verify that code in the tabular index. Here's an example. So if the coding is the phrase carcinoma of the uterus, first you would reference the term carcinoma. In the index, after the main entry of carcinoma, the cross-reference note appears that reads, "See also neoplasm by site malignant." So that carcinoma is telling us malignant, right? And then so what you would do is you would refer to the neoplasm table, look up by site, and go to your malignant um, column for your code. Okay, so your neoplasm table is organized alphabetically by anatomical structure, which is what I just said, and then the table is divided into your 6 columns. We've already gone over that. Okay, overlapping tumors. When a primary malignant neoplasm overlaps 2 or more contiguous sites, it is classified to a subcategory code .8, signifying the overlapping lesion. So we're going to look at a few examples here. What you're going to do is go into your neoplasm table and go esophagus. And esophagus is on page 347. And you're going to see where underneath esophagus, you're going to have several sites. It says abdominal, cervical, distal third, lower third, middle third, and then you see that part where it says overlapping lesion, and then proximal third, thoracic, upper third. Okay, so this one is saying carcinoma of upper and middle third esophagus. So we're going to go with C15.8. All right, so then that second one, carcinoma of oral cavity and pharynx. This one's a little bit trickier. When you look at neoplasm, what we're going to do is go to pharynx first. Because oral cavity, when you go to oral cavity, it's kind of confusing. But if we go to pharynx, and where you see next to pharynx, it says C14.0, and I'm in the neoplasm table right now with this. So under pharynx, it says C14.0, and when we go to the tabular for C14, you're going to see that it says malignant neoplasm of other and ill-defined sites in the lip, oral cavity, and pharynx. So that is covering both of my pharynx and my oral cavity. So once we see that, then we're going to go to C14.8, which is malignant neoplasm of overlapping sites of lip, oral cavity, and pharynx. And that is our code, C14.8. And then the last one, which is adenocarcinoma of rectum and anus. When we go to rectum and anus, and that is on page, one second, I'm trying to find it. On page 355, you'll see It says overlapping lesion with anus or rectosigmoid junction under rectum. So we would use code C21.8 for that one. Okay, and here are the answers, which we already talked about. C15.8, the C14.8, and C21.8. Okay, multiple neoplasms. When there are multiple neoplasms of the same site that are not contiguous, which such as tumors in different quadrants of the same breast, you would code each site would be assigned. So for this one, 52-year-old female, 2 distinct lesions of the right breast, both malignant. They documented that one was 0.5 centimeters in the upper outer quadrant and one was 1.5 centimeters in the lower outer quadrant. So at this point, you could pause your recording and go and look for those codes and then press play again once you've found the codes. I'm going to advance to the next slide with the answers, which is C50.411 and C50.511. Okay, a patient may have more than one malignant tumor in the same organ. So these tumors may represent different primary cancers or metastatic disease, depending on the site. When the documentation is unclear, the provider should be queried regarding the status of each tumor in order to select the correct codes. When more than one primary cancer occurs in the same organ system, these are called synchronous primary cancers. All right, let's look at an example for this. A patient with stage 4 non-small cell lung cancer of the left lower lobe is admitted with an extensive peritoneal metastasis and liver metastasis. A CT scan of the lung shows a large tumor in the left lung base with diffuse extension to the right lung. When queried, the provider documents that the tumor had started in the left lung and metastasized to the right lung. Because the provider has clearly documented that the primary malignancy of the left lung had extended to the right lung, we would assign the following codes. Your principal is going to be malignant neoplasm of lower lobe left bronchus or lung, C35.32, and then you're going to have 3 secondaries. Secondary malignant neoplasm of the right lung, C78.01, and then you also need your metastasis to your peritoneal and your liver. So that would be C78.6 and C78.7. So the terms metastatic and metastasis are often used ambiguously describing neoplastic diseases, sometimes meaning that the site is the primary and sometimes meaning that it's secondary. When the diagnostic statement is not clear in this regard, review the medical record for further information. However, when none is available, the following guidelines will apply. The statement metastatic to indicates that the site mentioned is secondary. So for example, a diagnosis of metastatic carcinoma to the lung is coded as secondary malignant neoplasm of the lung. The statement metastatic from indicates that the site mentioned is the primary. So a diagnosis of metastatic carcinoma from the breast indicates that the breast is the primary site, and a code for the metastatic site should also be assigned. So when they say metastatic carcinoma from the breast, you're going to be looking for, okay, well, where did it go to from the breast? And so you're looking for that code for the metastatic site as well. So another example is a diagnosis of metastatic renal cell carcinoma of the lung. And so this indicates that the primary site is the kidney, your renal cell, and then the secondary site is the lung. So metastatic renal cell of the lung. All right, so when specific site for the morphology type is not indicated in a code entry or is not indexed, assign the code for the unspecified site within the atomic site. So what this means is oat cell carcinoma, which is most common subtype of small cell lung cancer, of a specified site is indexed to C34.90, which is malignant neoplasm of unspecified part of unspecified bronchus or lung. And so we use this when no more specifics, when a more specific site is not stated in the medical record. So that's what we're going to use. Okay, when only one site is described as metastatic, without any further qualification, and no more definitive information can be obtained by reviewing the medical record, you would code that as the primary condition of the site. So if it says metastatic, whatever the site is, that's going to be your primary when you've got no more information listed in the record. And then what you would do is code your C79.9 as your secondary neoplasm, and that would be your secondary neoplasm of unspecified site because you don't have any more information. So an example of this would say metastatic carcinoma of the right lung. So you're going to do your primary malignant of the lung, C34.91, and then you're also going to code your C79.9 because you don't know what site it metastasized to from the lung. When you have two or more sites are described as metastatic in the diagnosis statement, each of the stated sites should be coded as secondary. You would also code C81.0, malignant neoplasm unspecified, should be assigned when no primary site information is available in the record. So this should be rarely used in the inpatient setting because you should always have more information in an inpatient setting because they're there longer. They're at the hospital. They're not going to discharge them until all of the questions have been answered, usually. So, and then you would code C80.0, disseminated malignant neoplasm unspecified. It's usually only used in cases where the patient has advanced metastatic disease and no known primary or secondary sites are specified, and this should not be used in place of assigning codes for primary site and known secondary sites. Okay, so primary now history. So when the primary neoplasm has been excised or eradicated and is no longer under any type of treatment, then we would code from Z85. No code history, history code, no Z85 would be used if you're assigning um, or if the history is benign, if it was a benign neoplasm or a carcinoma in situ, um, we there's no history code for those um, or of uncertain behavior. It's only for malignant tumors that have now been excised or eradicated and are no longer any um, treatment is being given. When a solid tumor has spread to the lymph nodes, a code from category C77 is assigned. So, adenocarcinoma of right female breast with metastasis to lymph nodes of the axilla, you would code the C50.911 for your neoplasm of the right female breast, and then C77.3 for your secondary um, neoplasm of the axilla and upper lymph nodes. All right, so these are a few for you to try. At this point, you would pause the recording so that you can go ahead and try some of these, and then you could come back and press play again. I'm going to advance the slide right now to show you the answers. And just let me know if you have any questions on any of these. Hodgkin's lymphoma. Hodgkin's lymphoma is a type of cancer originating from lymphocytes. It's categorized by orderly spread of disease from one lymph node group to another and by development of systematic symptoms with advanced disease. It can be treated with radiation therapy, chemotherapy, or hematopoietic stem cell transplantation. Category C81 provides a fourth character subclassification to identify the pathogen logic subtype of Hodgkin's lymphoma, and the fifth character is to identify the lymph nodes affected. Non-Hodgkin's lymphoma is a heterogeneous group of malignant lymphomas um, that present a clinical picture that is broadly similar to Hodgkin's disease, but with the absence of the giant Reed-Stumberg cells that are characteristics of Hodgkin's lymphoma. And so similar to category 81, Hodgkin's lymphoma, the categories of 82 through 85 provide a fifth character to identify the lymph node affected. Multiple myeloma and malignant plasma cell neoplasms. So multiple myeloma and malignant cell neoplasms are classified to category C90 with a fourth character indicating the particular type of neoplasm. Leukemias are classified in categories C91 through C95 with the fourth digit character indicating either the stage of the disease or the type of leukemia. And for all codes in categories C90 through C95, a fifth digit is used to indicate the status of the patient as follows: not achieving remission, in remission, and in relapse. So the fifth character 0 is assigned if the documentation does not indicate that the patient has achieved remission. When the provider documents that the malignancy is in remission, you would assign a fifth character of 1. If a patient experiences a recurrence and the provider indicates a relapse, then you would assign character um, to a relapse, the fifth character to relapse, A. Reoccurrence can occur at any time during the therapy or after completion of treatment, even months or years after remission. It's important not to confuse in remission with personal history. Personal history codes identifies a patient's past medical condition that no longer exists and they're not receiving any treatment, but has a potential for reoccurrence and therefore may require continued monitoring. If the documentation is unclear to whether the leukemia, the myeloma, or the malignant plasma cell neoplasm should be coded as in remission, then you should query the provider. Okay, let's try a few of these type of codes. And here's where you could pause the presentation and go ahead and complete this exercise 1 through 10, and then you could press play again to check your answers. I do recommend that you actually go through and look these up in the book, and that you don't just write down the answers. Um, a lot of what coding is practice, 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 and practice makes perfect. And going through the book to see what you will find for each of these is very important in the coding process. Okay, so I am going to advance to the next slide to give you the answers for these. And if you have any questions on finding any of these, please let me know. All right, so sequencing of codes. When treatment is directed towards the primary site, the malignancy of that site is designated as principal diagnosis. Basic rule for designating principal diagnosis is the same for neoplasms as for any other condition. That is, the principal diagnosis is the condition found after study to have occasioned the current admission or encounter. There's no guidance that indicates that a code for a malignancy takes precedence. However, because the principal diagnosis is sometimes difficult to determine in a patient with malignant diagnosis, with malignant neoplasm, the thrust of the treatment can often be the guide to select the principal diagnosis. So if the treatment is directed towards the secondary site, the malignancy of that site would be designated as the principal diagnosis. When a patient is admitted because of a primary neoplasm with METs and treatment is directed equally towards the primary and the secondary sites, then the primary malignancy should be designated as the principal. The only exception to this guideline is if the patient's admission encounter is chiefly for the administration of chemotherapy or immunotherapy or external beam radiation therapy. And if you would take a look at the wording that I have on this slide and the wording in your guidelines for 2023, it says solely. The new guidelines, the ones that were released or that will be released on October 1st, this wording is going to change to chiefly. So they just changed it from solely to chiefly to kind of give some clarification on this. For the administration of chemotherapy So since the word solely is crossed out and chiefly is there, so that's what I was trying to show you, is that this is the new wording for October 1st. So in those cases, when it's the patient is coming in for the chemotherapy or the immunotherapy or the radiation, specifically for those, then you're going to use the Z code for the therapy, for the chemo or the radiation or the immunotherapy, instead of uh, the code for the neoplasm. So here's your code for the encounter code, um, and the Z51.0 is for radiation therapy. Um, your Z51.11 is for your chemotherapy, and your Z51.12 is for your immunotherapy. These are going to be first listed principal diagnoses. If a patient receives more than one of these therapies during the admission, more than one of these codes may be assigned, and they could be in any sequence. It really doesn't matter. Okay, sometimes you'll have two primary sites that are present. In this case, you would code each as a primary neoplasm. When treatment is directed primarily toward one site, um, the neoplasm of that site should be designated as the principal diagnosis. When treatment is equally toward both of these sites, then you can designate either as principal. All right, so here's two examples. Patient with severe urinary retention due to hypertrophy of the prostate is admitted for a prostatectomy. Transurethral resection of the prostate is carried out, that's your TURP, and the patient is discharged with a diagnosis of benign hypertrophy of the prostate. When a pathology report is received, this diagnosis is confirmed, but a microscopic focus of the endocarcinoma is also identified. Sorry, adenocarcinoma is also identified. So in this case, you would code N40.0 for your benign prostatic hyperplasia with lower urinary tract symptoms as your principal. And then you would code C61 for a malignant neoplasm of the prostate, and then your retention of your urine is your R33.8. The second example is a patient admitted for treatment of endometriosis of the uterus. Total hysterectomy is done. Pathology report confirms the endometriosis but indicates carcinoma in situ of the cervix is also present. So in this case, your endometriosis is the reason for the admission, remains principal. An additional code is assigned for the cervical neoplasm. All right, patients with malignant neoplasms often develop complications due to either the malignancy itself or the therapy they've received. When the admission is primarily for treatment of the complication is coded first, followed by the appropriate code for the neoplasm. The exception to this guideline is anemia, when the admission encounter is for management of an anemia associated with the malignancy and is treated, then the treatment is only for the anemia. The appropriate code for the malignancy is sequence as principal, followed by the anemia code, anemia and neoplastic disease. When the admission encounter for a management of an anemia associated with an adverse effect of administration of chemotherapy or immunotherapy, then only and the only treatment is for the anemia, then the anemia code is sequenced first, followed by the appropriate code for the neoplasm and the adverse effect. So an example of this would be a patient with metastatic non-small cell lung cancer of the right upper lobe develops anemia following chemotherapy. Patient presents to the oncologist for treatment of the anemia of chemotherapy. And in this case, you would code D64.81, anemia due to your chemotherapy. Your C34.11 is your malignant neoplasm code. Your C79.9 is your malignant neoplasm of unspecified site. Because you go back to metastatic non-small cell lung cancer. So that's the only cancer that we have. So we're going to code that as primary, but we don't have the secondary site. So that's why we're coding the C79.9. Then your anemia code of anemia and neoplastic disease. And then you're going to have an adverse effect code as well, your T45, because the chemotherapy is creating the anemia. All right, so then when you have an admission encounter for management of anemia associated with an adverse effect of chemotherapy, the anemia would be sequenced first, followed by the appropriate code, neoplasm code, and then your Y84.2 for your radiological procedure and radiotherapy as the cause of the abnormal reaction that the patient's having. Okay, so in this case, a female patient with cancer of the right breast seen for a blood transfusion to treat the anemia related to the radiation therapy. So your primary would be D6489 for other specified anemia, and then your malignant neoplasm code, and then your Y84.2 for the radiotherapy. All right, so when the admission encounter is for malignant, for management of anemia described as cytopenia due to chemotherapy, then you would code D61.810 for the pancytopenia caused by cancer-fighting drugs. In cancer patients, pancytopenia usually occurs due to bone marrow suppression from chemotherapy. So in this example, a female patient with cancer of upper outer quadrant of the left breast develops pancytopenia during chemotherapy, and the patient presents to the oncologist for follow-up for the pancytopenia. The oncologist listed chemotherapy-induced pancytopenia as the diagnostic statement. So you would sign code D61810 for the induced pancytopenia, and then your C50.812 for your malignant neoplasm, and your T45 code for the adverse effect of the chemotherapy. Okay, when an admission encounter for management of dehydration due to malignancy or therapy or a combination of both, and the only dehydration is being treated, then that is sequenced first, followed by the code for the malignancy. Because the principal diagnosis may be difficult to determine, the focus of the treatment can often be used as a guide. So in this example, a patient underwent treatment for prostate cancer, is admitted for chronic constipation, causing excruciating pain in the stomach and the back. An enema was performed, and the patient was given Colace and advised to increase fiber intake. So what is coded as principal is your constipation, K 59.09, then your C61 for your prostate cancer. Um, so in this case, they were admitted and treated for chronic constipation, and there was no treatment directed at the malignancy. Codes from Chapter 15 of ICD-10-CM, pregnancy, childbirth, and the perineum, are always sequenced first on the medical record. A code from subcategory 09A.1, malignant neoplasm complicating pregnancy, childbirth, and the perineum, should be used first, following the appropriate code from the Chapter 2 to indicate the type of neoplasm. Incidentally, in the case for all pregnancy coding, you would always start with a code from the Chapter 15 that starts with a 0. So anytime that you're coding for a pregnant patient, know that those codes are always going to take precedent over any of the other codes. Those are going to be your principal codes always, end of story. If the patient is pregnant, you're going to have an O code that is principal. Pathological fractures. Sometimes you'll have a pathological fracture due to a neoplasm if the focus of the treatment is the fracture. A code from M84.5, pathological fracture and neoplastic disease, should be sequenced first, followed by the code for the neoplasm. So if the focus of the treatment is the neoplasm, then an associated pathological fracture in the neoplasm code should be sequenced first, followed by the code from M84.5. So again, just depending on where the treatment is associated. Malignant ascites. These are abnormal buildup of fluid in the abdomen caused by the malignancy. Diagnostic tests to determine the underlying cause may involve blood tests, ultrasounds of the abdomen, paracentesis. Treatment may include diuretics, therapeutic paracentesis, and other therapies directed at the underlying cause. An example here would be a patient admitted with pancreatic cancer with massive, widespread malignant ascites. The final diagnosis is pancreatic cancer with malignant ascites and metastasis to the retroperitoneum. Therapeutic paracentesis is performed. And in this scenario, you'd code your malignant neoplasm of the pancreas as your principal, your malignant ascites, which would be your R18.0, and then your secondary for your neoplasm, retroperitoneum, and peritoneum code of C78.6. And then your PCS code here for your therapeutic peritonesis would be 0W9G3ZZ, but we'll cover that next semester, so don't worry about those PCS codes just yet. All right, malignant pleural effusion can occur due to impaired pleural lymphatic drainage from the mediastinal tumor, and not because of direct tumor invasion to the pleural. So a lymphoma is obstructing the drainage system, which usually caused by disturbance of normal starring forces regulating reabsorption of fluid in the pleural space. Code for the malignancy is assigned first, and then a code for the malignant pleural effusion is a secondary code. Sometimes people decide to prophylactically remove an organ due to a family history of cancer or genetic susceptibility to cancer. My sister did this because she tested BRCA1, which my mother also tested for. She had both breast cancer and ovarian cancer, and the ovarian cancer um, took her. But so we all, as her children, all got tested. My sister was the only one that tested with the same gene, the BRCA1. So she prophylactically went in and had her breast removed, and also had a hysterectomy done. So for her case, we would code principal diagnosis code of Z40, which is an encounter for prophylactic surgery. And this code should not be assigned if the patient's having organ removal or treatment of a malignancy. This is just prophylactic surgery. Follow-up encounters of Z08. So once malignant neoplasm has been excised or eradicated, there's a period of follow-up exams that are carried out due to their, they wanted to test to make sure that there's no reoccurrence of the primary malignancy or any spread to a secondary site. And so when there's no evidence of reoccurrence at either the primary or metastatic site, then we would code Z08 for that follow-up examination. You would use an additional code of a personal history of malignant neoplasm if you've, and also a code for the acquired absence of the organ. If there's no evidence of reoccurrence of the primary site, the code for the malignancy, if there is evidence of reoccurrence, then you would code the malignancy as the principal. Um, If there is no reoccurrence at the primary site, but there's evidence of metastasis to the secondary site, then a code for the secondary neoplasm along with the history of the primary would be used instead of the Z08. All right, so here's a true-false recap. The occurrence of an original primary neoplasm that was previously removed is classified to Z85, personal history. And that is false because when there's reoccurrence, then we would use our malignant neoplasm code. If a primary malignant neoplasm was excised previously and the original primary site has not reoccurred, assign the code for the previous primary malignant neoplasm using the appropriate code from the C00 through D49. And that's also false because in that case, we would use the personal history code of Z85 because it was excised and it has not reoccurred. All right, so number 3, whenever secondary neoplasms are present, the Z code for identifying personal history of malignant neoplasm can never be sequenced as principal for uniform discharge data set purposes. So this is saying you have a secondary neoplasm that is present, so that would be your principal. It would never be your primary Z code because that's just stating that it's identifying that the person has a history of a malignant neoplasm. That would never be the reason why a patient would come in. So that Z code would not be principal, and especially when you have an active secondary neoplasm. All right, so that's kind of what I just went over and the reasons why highlighted there. All right, think, pair, share activity. So Kim Young is admitted for treatment of pathological fracture due to a neoplasm. The focus of the treatment is the fracture. So which coding guideline applies to the sequencing of the codes for this case? And at this point, you could pause this recording and then answer it. But here we go with the answers on the next slide. When an encounter is for a pathological fracture due to a neoplasm, then the focus of the treatment is the fracture. The code from M84.5 is going to be sequenced first, and that is from coding guideline C2.I6 or 16. All right, coding practice activity 1. So select the current code for renal cell adenocarcinoma of right kidney. And you could pause. Right, here we go is the answer. So your main term to reference in the index would be adenocarcinoma. Your modifying term would be renal cell, and your code assignment would be C64.1. Here's another one, encounter for radiation therapy. Here's your answer. So you would go to encounter in the index, radiation therapy, and then your code assignment would be Z51.0. All right, so we've come to the second to last slide here. What do you feel is the most difficult concept that relates to the coding of neoplasms and why? I think the biggest hurdle here for me, I don't know if it's for you guys, is just making sure when you're reading the text, you're understanding the difference between a primary and a secondary um, neoplasm. And if you can get that down, then the rest is easy peasy. I hope this presentation was helpful. And in summary, um, now that the lesson has ended, you should have learned how to identify the groups of neoplasms, identify a neoplasm as benign or malignant, apply the coding guidelines to select and sequence, and be able to do those case studies. I hope this was helpful. See you guys later.